Okay, we'll get started. Um, Great job on that second patho exam. Everyone did very, very well. Seems that a lot of you guys are starting to figure out your study habits, what works well, how to get all this information inside and keep it in there, um, and apply it for other things going forward. So this third unit has 3 topics. First one is musculoskeletal. The second one is renal. And then we'll do neuro towards the end. So it's those 3 for this unit. The last unit is GI and then all the endocrine stuff. So that's the last one. So we didn't do very, very much in physiology with bone and stuff. So we'll do a little bit of review and kind of go over anatomy and phys with regards to bones. We'll go through some disorders as well. So today we're going to do connective tissue disorders, just Marfan syndrome, and then disorders of the cartilage. We'll deal with joint problems on Thursday or Friday, whatever we have class again. I think it's on Friday. We'll finish up musculoskeletal, and then we'll do the rest of the stuff then. So here's our objectives for today. So connective tissue, very abundant. Includes fibrous tissue, adipose tissue, cartilage, blood, and bone. Those are all considered connective tissues. Function binds organs together. Structural framework for an organ. Basically, we would just be a mass of just skin and guts if on the ground if we didn't have skeletal structure giving us form. Protects our organs, our rib cage protects our vital organs. And obviously, connective tissue varies greatly in vascularity. Why is that important? Injury, what about it? Healing. You got to have blood supply to heal things. Cartilage and ligaments don't have a very, very good blood supply. So they don't heal very well. So we get to like ankles, and you get to like ortho, they'll say it's better to break your ankle than to sprain it. Because the bone has a lot of blood supply, it's going to heal easier. But if you sprain the ankle, those ligaments get stretched. They don't heal very well. They take a long time to heal because of blood supply. So here's an example of just the different types with what we talked about, different types of connective tissue and where they're found and whatnot. So when it comes to cartilage, this is the surrounding part of the bones. There are 3 major types that we're going to be talking about. First one is hyaline cartilage. This is articular cartilage that lines the joints. So when your elbow moves, the articular cartilage is on the end of the bones. It allows very, very smooth motion, very, very little friction. We have fibrous cartilage. This is a mixture of cartilage and fibrous tissue. This is like the pubic symphysis that will start to become very pliable later on. The reparative response to injury created fibrocartilage. And then we have elastic cartilage. They have elastic fibers, like the cartilage in your ear is elastic. You can bend your ear around, but it's cartilage. It bounces back. And again, just where they're located, our hyaline cartilage is on all the joints. Elastic cartilage, again, in the ear. Fibrous cartilage, your pubic symphysis, and even your vertebral discs in between the vertebrae. That is a type of cartilage as well, but it's fibrous cartilage. It has some compression because of movement. It can also cause a herniated disc if that thing bulges in and compresses the spinal cord. So that's where that comes in. So hyaline cartilage, it appears white, has a very slick or slippery feel, has a consistency of a tennis ball. We want to reduce friction. We want those things to move very, very easily so it doesn't cause pain when they move their joints. Very flexible and resilient. Collagen is the only fiber present for hyaline. So you hear collagen, it's for joint health as well as like skin and stuff like that. No blood vessels. So again, if you damage this articular cartilage, like we get to like osteoporosis, and not osteoporosis, osteoarthritis and rheumatoid arthritis, you're going to see the changes that happen with the cartilage here. Also known as articular cartilage because it's on the articular joints. Anything that moves has to have hyaline cartilage. So as an example, here is where the hyaline cartilage is on the end of the femoral head. Prevents plastic deformation. So when loaded, it won't crack. And we also, mineralization of this chondroid matrix takes place during growth in the epiphyseal plate. So this plate is very important, this growth plate right there. Okay? When we talk about fractures, especially in kids, and we'll get to this very, very end of the whole musculoskeletal section, you have to know, especially in kids, was the growth plate fractured as well? Because if the growth plate was fractured, they may have problems with growth of that bone. So when we get to different types of fractures, later on, you get this a lot more in ortho, obviously. The type of fracture dictates the severity of the involvement of the growth plate. Was the growth plate totally cracked? Was it split above the growth plate where it was? So knowing that growth plate is very important as well. Fibrocartilage is a little bit grayish white. This more has a leathery feel, like soft leather. Less plasticity than the hyaline, but resists deformation better than the hyaline. So fibrocartilage, again, these are the things in your vertebral column. Compression, you're standing up all the time. If you jump up and down, okay, there's compression forces going on in your vertebrae every time that you jump. This type of fibrocartilage prevents the deformation and allows for support while you're doing those activities. So seen in pubic symphysis, the menisci of your knees especially, and your vertebral discs is where you would find this type of cartilage. And then your elastic one, the last one, epiglottis, larynx, your outer ear. So those are just areas of elastic cartilage. Now let's talk about the types of joints that we have in our body. We have fibrous joints or synarthrodial. These have no movement at all. So it's a joint, but there's no movement in the joint. No cartilage lining because there's no movement. You don't need the cartilage there for the support and everything, so you don't need it. Joined by fibrous connective tissue. This is your cranial sutures. So remember when we're born, we have all the different cranial bones. They are not fused yet, but later on as you grow and you get older, the sutures start to fuse and they become joints now, but they are fibrous. There's no movement in those joints. Distal tib fib is also another example. Cartilaginous joints. These are amphiarthrodial. They have very minimal movement, but they do have some movement. Fibrous cartilage, ligaments, your costochondral joints. What's that? Ribs, where they connect to the sternum. There's cartilage all along the lining of the sternum. If that gets inflamed, when you breathe in and out, that joint is going to move slightly, causing pain. It'll feel like chest pain to people when they come to the hospital. So what kind of questions would you want to ask that person to see if it's musculoskeletal pain or is it cardiac pain? Does it hurt when you breathe in and out? Cardiac pain does not hurt when you breathe in and out, but this pain will because the joint is moving ever so slightly. What's another clue that it's musculoskeletal pain?
It has like
A specific point to an area where it hurts. Just tell your patient, where does it hurt? Show me. Don't give them any clues, and they'll go like this. It hurts right here. They'll point to an area. Well, it's tender. Okay, well, that's probably costochondritis, inflammation of the cartilage at the joint, causing chest pain. But again, your history that you're asking those questions will clue you in, is this more important or less important as far as the heart attack stuff. Last type of joint is synovial. This is the freely movable one, so you guys do your whole dance. When you get range of motions, you're testing these type of joints. Has hyaline cartilage, has synovial fluid, and that's why they're called synovial joints. The synovial fluid is like the liquid that kind of provides lubrication in the joint to allow it to move freely. So knee, your TMJ, and so forth. So it's just, again, graphical, showing you the different types of cartilage and the different types of joints and whatnot, and where cartilage is present and where it's not. So our synovial joints is what we're going to be focusing on the most, because that's where the most of the problems come into play. We have an articular capsule. The outer layer is called the fibrous membrane, the outer layer of the joint. Then when we go inside, we have a synovial membrane. This is the inner synovial layer. The smooth lining of the joint capsule has blood and lymphatic vessels in this, because obviously that synovial fluid has to be recirculated, brought back in, new one dumped into the area. So there has to be some circulation going on. And because it's got blood supply and lymphatics, capable of repair and regeneration. Blood supply is so important. Look at the signs of no blood supply to an area. What's one of the earliest signs you can tell if someone has got peripheral vascular disease? No hair growth on the feet, toes, lower extremities, because you need blood supply to do that. And if you don't have the hair growth where they normally had it, that means they're dying off. It has alpha cells and beta cells. I think in the formatting I just messed it up, but it's alpha and beta cells. The alpha cells in the joint help with bacterial and debris, getting rid of it, and the beta cells secrete the hyaluronic acid that provides the viscosity, the thickness. The hyaluronate. Sometimes you'll see like supplements that have like hyaluronic acid and stuff like that, help with joint pain and all that stuff. Theory is supposed to help with the viscosity of that joint fluid, help with easing of that joint pain. The joint space is filled with synovial fluid, and then we have our articular cartilage finally in the inner layer. It's hyaline cartilage, and obviously it's going to be very, very white and slippery. So here's an example. Here we have the joint capsule right here. We have the fibrous articular area in the green. We have our synovial membrane in the yellow. And we have our synovial fluid. That's all the pink stuff inside the joint. Then we have, to create our final borders, we have the borders of the bones, and we have the articular cartilage in blue, providing that final barrier. So these are like the four walls of the joint. We have the outer layer, fibrous articular. We have the synovial membrane, synovial fluid, articular cartilage. And that is basically what our joint is. Whether it's your fingers, your elbows, shoulder, knee, all the same principles. So the synovial fluid, two main purposes: lubrication to reduce friction, and helps with nutrition for the articular cartilage. It's got fluid right there, got nutrients, it'll help keep that articular cartilage healthy. Diffusion of oxygen and carbon dioxide electrolytes through the chondroid matrix is aided by pumping action of weight bearing. So just by walking helps with pumping action, just like the skeletal muscle pump. Also walking helps with diffusion of all these oxygen, CO2 to come in and out. And is impeded by increasing polymerization or calcification of the matrix. So when you start damaging that articular cartilage, you're not going to have the same properties anymore. In monoarticular arthritis, what does that mean? One joint. So if you have one-sided joint pain, just my right knee is killing me, just the right knee. If it was both knees, that's polyarticular. But we only have one problem. So if you ever have someone coming in and they have a joint pain in just one joint on one side, do a synovial fluid analysis. You can do a needle stick, put a needle inside that joint, pull the fluid off, and see what it is. So this is what happens with synovial fluids. We talked about the viscosity of that fluid and how the hyaline provides, or hyaluronate provides the viscosity of the hyaline, the synovial fluid. So the more hyaline, the more thick and viscous the fluid is. And we want thick, viscous fluid. It helps with the movement. So when you have the synovial fluid and you just let it drip off the needle, you want to see how long a string it makes. The longer the string, the less edema fluid and the less hydrolyzed the hyaluronic acid is. So the longer the string, the better it is. If that string falls off halfway, that means there was a lot of water in that area, some more edema, making the viscous reduce so it's very thin, and it won't hold on to it anymore and it falls. So that's the first test that we do. That tests the viscosity of the fluid. Then we let the drop fall into vinegar. And we see what happens when we add that drop in the vinegar. If you have clear fluid and that clot of the synovial fluid is still, together, that drop still stays formed, that could be either normal osteoarthritis, trauma, or bleeding. Basically, there's no infection at this point. So clear fluid, solid clot, that's normal synovial fluid. Nothing's wrong with that patient. It could be osteoarthritis causing the pain. It could be trauma to the area causing that problem. But the synovial fluid is normal. On the very other side, I want you to know the other side as well. If the synovial fluid totally dissolves in the vinegar, there's no clot, it is totally cloudy, this could either be gout or gonorrhea. Gonorrhea can affect your joints as well. So if the middle stuff, don't worry about for now. You'll get all this more in room with Dr. Ovalle and ortho. But for now, know the extremes. When you drop the synovial fluid in vinegar, if it stays the same, it doesn't dissolve, that's normal or non-infectious. Osteoarthritis, trauma, and bleeding, those are not infectious problems. They're inflammatory problems. Gout and gonorrhea are infectious inflammatory problems. Well, gout not so much infectious, but gonorrhea definitely is infectious. So you have your extremes. Gout we'll deal with on the next section of this lecture on Thursday or Friday. So make sure you understand the far extremes, what happens when you put the synovial fluid in the vinegar. So you can see here with normal synovial fluid, good mucin clot test, which is what we're describing in the last section with the vinegar. White blood cells around 200. If I'm circling things, I want you to remember these ones. Rheumatoid arthritis, poor clot, cloudy, 15 to 20,000 white blood cells. And the last one is infectious arthritis. This is your gonorrhea. Purulent, so a lot of pus because it's an infectious problem, so there's going to be a lot of white blood cells causing the pus to form. Very poor clot and lots of white blood cells in that area. So understand what a normal one looks like, rheumatoid arthritis and infectious arthritis. Always think, is this inflammatory or is this infectious? Obviously, it's inflammatory. You can have a reaction causing white blood cells to go up, but infectious obviously will always have very, very high white blood cells. If I gave you a question, and let's say I said there were 50,000, or let's say there were 10,000 white blood cells, and it could either be rheumatoid arthritis or it could be infectious arthritis. As we go through rheumatoid arthritis later today, you'll see that rheumatoid arthritis is bilateral. It's going to affect both sides of the body equally, whereas an infectious arthritis is going to be usually monarticular. One joint is going to be infected. So one joint for infectious, usually going to be one joint. So the history is going to tell you a lot what's going on with that patient. Rheumatoid also is an autoimmune disorder. So I talk about anything about autoimmune problems. Rheumatoid might be the answer. So the joints we have provide, again, smooth, frictionless surfaces for motion. When you start cracking that articular cartilage, it's like having sandpaper exposed. And when that joint starts to move, it can rub against basically that rougher surface and cause pain in that joint. which will then cause inflammation. So when you are nice and clean, that articular cartilage is nice and slick and white, you don't have any friction, no pain. Energy absorption provided by the physical characteristics we talked about. Again, they can compress a little bit. They have some plasticity to them. When you jump up and down, you don't just break everything in your spine. Weight bearing, okay, is also a function of our joints. The load is relieved, matrix resumes to its former shape without damage. So what happens is when you run and do things, your bones they'll deform a little bit, but they come right back to normal. But it's very, very, very minute deformities when they move. But when that happens, the bone gets stronger, and that's called Wolff's Law. When you have weight-bearing activities, the bones get stronger. That's why weight training for elderly is so important. And it doesn't need to be a lot. You can just get a gallon of milk filled with water. They can just lift that. It's like 5 pounds, I think. Find anything your patients could do. But when they start walking in elderly, what's the biggest problem with elderly patients? Falls. And what happens when they fall? They break things. So if we get stronger bones by having them lift weights and work out, they can support themselves when they walk. And if they fall, they have a better chance of not breaking things because they have stronger bones. It's the ones that are very frail, sedentary, don't move, those bones get brittle and weak. Some supporting structures. We have our tendons, which attach skeletal muscle to bone, and ligaments, which are bone to bone. So any questions on the anatomy and phys of any type of musculoskeletal? I'm not going to ask you anatomy questions on your exam. But so we all have the same definition, starting point when we move forward. Moving on. So Marfan syndrome. Autosomal dominant. So it's a genetic disorder. It's inheritable. Disorder of the connective tissue. So there's a genetic component to here. So 30% of people will have a family history of Marfan syndrome. Or do not have a family history. It's called sporadic spontaneous mutation. But majority of the people will have a family history of Marfan. 1 in 5,000 people, men of all women and all races. So should you study that point for this? No, they're all the same. Skip it, move on. Those affected may or may not display any signs and symptoms of Marfan at birth. So per the Marfan Foundation, our community of experts estimates that nearly half the people who have Marfan don't know they have Marfan. They don't get diagnosed till later in life. When they start growing and all the signs and symptoms of Marfan get exaggerated when they grow. So the gene that causes the Marfan issue is called fibrillin 1. Okay, fibrillin is essential to cartilage remodeling and maintenance of the elastic properties. So when you have a fibrillin defect, that allows the long bones to become way too long. So the defect is in this fibrillin 1. Okay. The mutation resulted in an increase in the protein called transforming growth factor beta, or TGF beta, which causes the problem with connective tissues in the body. So here are some signs and symptoms. Tissues affected, skeletal system, of course. You're going to have issues with long bones, eye issues, aortic valve problems, and aortic problems. The majority of Marfan's patients at some point in their life will require an aortic valve replacement. What is the murmur called when the aorta dilates and the aortic leaves don't touch anymore? What kind of valve disorder are we causing? Aortic regurg. So what happens is with these patients, the aorta dilates to the point where the aorta leaves don't touch anymore. And therefore, they causes an aortic regurg to occur. So what happens with these patients is they'll get a whole, it's called a ball and stem replacement. They'll put a graft in of the base of the aorta with a valve attached to it, and they just put that whole thing in and replace your aorta that has been dilated. That's how they fix that. Lung issues, obviously if the thorax is expanding, the lungs have to grow with it. If the lungs don't grow with the expanding chest cavity, the chest wall recoil will be strong, the lung recoil not as strong enough, and what would you think they would start getting if the lungs and the chest wall don't like each other and they detach? Collapsed lung, but we're in medical school now, so pneumothorax. They get a lot of spontaneous pneumothorax because of the height, the lungs collapse. So physical exam finding: tall, thin body, long limbs, long fingers, arachnodactyly. They have very long fingers. Disproportionately long arms, legs, fingers, and toes. You guys all know this trick. Your wingspan of your arm should be the height of you. So if you put your arms out, go to the wall, it should be close to you. Marfan's patients, their wingspan is a lot longer compared to what they should be as tall they are. Like Michael Phelps, they think he has some sort of Marfan syndrome. He's got very, very long arms. Sunken chest is pectus excavatum. That's the sunken chest. Or they have the opposite. It's called a pigeon breast, which is pectus carinatum, where instead of sunken chest, it's puffed out. They may have flat feet, crowded teeth, hypotonia, flexible joints, dislocation of the lens. So that's where the eye problems come into play. A small jaw, and potentially scoliosis as well. So these are some physical exam findings. Complications of Marfan syndrome due to its effect on connective tissue disorder. We talked about rupture, dissection of the aorta. It dilates, gets bigger. Cardiac valve malformations. We talked about the aortic valve involvement and how that has a problem. Eye issues because of the lens issues causes vision problems. Here's your spontaneous pneumothorax that we talked about because the chest thorax gets wider and bigger. Scoliosis, high-risk pregnancy if you have Marfan's underlying. And then here's some people that had Marfan's. If you guys watch the movie Sinners that just came out, supposedly it's based off of that guy. That's Robert Johnson. He's supposedly the father of rock and roll, whatever. Supposedly he went out somewhere, and all of a sudden he comes back. He's like this amazing guitar player. The whole Soul, the Soul of the Devil is like based off of that guy. And then Michael Phelps and English King Tut. Anyway, that's Marfan's. Any questions about Marfan syndrome? Okay, now moving on to disorders of the cartilage. Okay, osteoarthritis, rheumatoid arthritis, and neuropathic joint disease. The big thing is know the differences between osteo and rheumatoid arthritis. They are both considered arthritis, but they have different etiologies and different symptoms when they start to present themselves. Neuropathic joint disease, we'll get to that later at the very end. Basically, diabetic neuropathy. They can't feel the bottom of their feet, and they continuously injure their foot because they can't feel it. They continuously step on Legos, they don't feel it, but it hurts. But they get injured, but they don't feel the pain, so they continuously re-injure it, causing problems. Okay, so here's your healthy knee, and obviously this is your osteoarthritic knee. All the cartilage has been degraded, and then the bone starts to degrade once the cartilage has been removed. And we'll go through the processes of all that stuff. So osteoarthritis is also known as degenerative joint disease. You have to be descriptive in your notes. If a patient has degenerative joint disease, describe where is it. DJD of the spine, cervical spine, lumbar spine, right shoulder, right hand, left hand, both hands. Where is it? Don't just say DJD. Where? What specific part of it? This is your wear and tear osteoarthritis. Okay, so with age and elderly people who do a lot of manual labor their whole life, they're going to have some form of arthritis later on. We get deterioration and abrasion of the articular cartilage, and then we get formation of new bone at the articular surface. Do you want bone to grow on that articular surface? No, you don't. And then you start getting bone on bone, which causes a lot of pain. And then eventually, if they don't take care of themselves, they don't get treated, that bone on bone eventually can fuse, and then you have a frozen joint because the bones fuse together. Worst case scenario, but can it happen? Yes. So osteoarthritis is the most common type of arthritis. There's different types. We're going to go through some of them. Again, primarily elderly people get osteoarthritis. If I said someone coming in, a young patient with arthritis, what else have we learned of that can cause arthritis? Psoriasis. That would be a cause for a young person to have arthritis in their 20s or 30s because they have psoriatic arthritis. That makes sense. That's the underlying cause. But in a normal, healthy, none of you people should have arthritis. You're all young. You shouldn't have any type of osteoarthritis. I'll put it that way. Anyone that was subject to trauma may develop osteoarthritis later on and affects weight-bearing joints and fingers of old people. So weight-bearing joints, what are your weight-bearing joints? Knees, hips, lower back, those are your weight-bearing joints, which makes sense. They're under the most load. They would be under the most stress. They would degrade over time due to that. And obviously your hands, the fingers. You see a lot of people with arthritis, they have it in their hands. They can't do things. So that's usually where it affects. And then here's, hips, knees, toes, and then your feet. Neck is an area too. People who have like carpal tunnel, don't just assume that it's coming from their wrists. It could be their neck from leaning forward at a computer all day, pinching, we have that brachial plexus right here. A lot of nerves, and you're leaning forward all the time. You can compress certain nerves, and it causes pain in your wrists. So that's frequent sites of involvement. So types of osteoarthritis. The first one is primary osteoarthritis. It's your degenerative joint disease. Joint destruction results from intrinsic defects in the articular cartilage. So we get degradation of the cartilage. When the cartilage degrades, joint space narrows. When you guys start looking at x-rays, especially of all the joints, you're looking for even joint spaces between, like if it's the fingers, you want to have the same size joint space in all the fingers. When you start getting joint space narrowing, and I'll show you some x-rays of that a little bit, obviously the joint won't work as well because you have joint space narrowing, less synovial fluid, bones can become closer to contact with each other, causing pain. We get subchondral bone thickening. Eventually the joint becomes non-functioning and painful, and the synovium may become mildly inflamed as well. So it's an inflammatory disease. Okay, it causes inflammation from the damage to the articular surfaces, causing pain and swelling. Increased incidence with age. Under 45, more men. Over 55, more women. Why do you think that is? Menopause, the estrogen. Estrogen helps with keeping your bone mass density up. And when you go through menopause, the estrogen drops, bone mineral density starts to drop as well. There may be some hereditary predisposition for osteoarthritis. Secondary is an identifiable source. So when you have osteoarthritis, if you can identify the underlying cause of it, then it's considered secondary. Any congenital issue, trauma, crystal deposits, we get to gout. Talk about crystal deposits, infection, any metabolic or inflammatory diseases, endocrinopathies, osteonecrosis, which is actually just death of the actual tissue of bone itself, and hemarthrosis. What's hemarthrosis? Blood in the joint. So you can see here the joint space, nice joint space there, and then look at the joint space here. You see how that joint space narrowing occurs? And obviously this is off kilter, it's not even in the right spot anymore. And then if you look at where they actually overlaid some color, you can see the fracture of that, probably your patellar. Another type, chondromalacia, which is a subcategory of OA, usually patellar surface of young patients, pain, stiffness in the knee. It's just the bone didn't grow right. And patellar is off kilter, causes pain and will mess up that joint. So chondromalacia is another form of osteoarthritis. So etiology, remember this is osteoarthritis. This is just a disuse, overuse injury, so it has to be overused. So increased unit load. You're doing a lot of work, and it puts more stress on areas that there shouldn't be. So when you have malalignment of the joint surface, you increase the load on less surface area. So in a normal bone, we have our, nice area right there where everything moves to have its own place. Now, if I mess up the bottom one, now all the stress is going to be on that one point. So that's the point that's going to crack because you have misalignment of the cartilage. You don't have a great surface anymore. You get these little bony growths at the end of these bones, that new bone forming over the cartilage. You don't have that nice slick surface anymore. Now you have like little valleys and crypts and mountains from all the different bone growth, and it causes misalignment and pain. Yes? Bone spurs, I think, are mainly caused by like the muscle with the ligament pulling the bone off the bone. It's like an avulsion fracture. It pulls it right off. Decreased resilience of that cartilage, so it's not going to be as resilient. It's going to crack easier because of this increased load on that surface area. Increased stiffness of subchondral coarse cancellous bone. The cancellous bone is on the inside. Damage to the coarse cancellous bone results in increased unit load. Again, putting more load on that joint on certain bone surfaces than it should be. So anytime you have an injury, remodeling to that joint, it's not going to be the same way it was before, and you may get increased stress. So mechanical forces are not transferred by normal stress, but are dissipated by microfractures. So like stress fractures. You hear that with a lot of runners from their feet, stress fracture from, again, repeated use. So that's what's going on with that one. So pathogenesis, why are we destroying the cartilage? Mainly involves proteoglycans. Proteoglycans allow connective tissue to withstand compression. So if you lose your proteoglycans, the cartilage can't undergo that compression anymore, and it's going to crack. So both proteoglycan content and the aggregation starts to decrease. We're starting to lose our proteoglycans. This one chain length is reduced, another proteoglycan. Protein synthesis eventually declines and fails to respond to that reparative stimuli. The bone wants to repair itself, but because it's constant being injured all the time with you walking, it can't repair itself well, and it just stops responding to it at all. So our chondrocyte cell replication diminishes, so we're not going to create new cartilage. We get chondrocyte apoptosis, so just cell death of the cartilage. Decreased synthesis of our collagen and extracellular matrix occurs. So all this good stuff, the collagen that we want, the matrix that keeps our bones strong, those are all starting to be reduced, and further degradation occurs of the bone. Products of inflammation, nitric oxide, and then this matrix metalloproteases further cause more breakdown of the bone. So this is what happens with osteoarthritis. This is OA. Keep it straight because rheumatoid arthritis is totally different. So let's look at the joint. Here's our cartilage. We have our tide mark, subchondral bone plate, and then there's our bone marrow. So this is normal surface. We're good. Now we start getting a crack in the hyaline surface. So now we have exposed area underneath. Do I have anything written here? No. Okay, so when you have this crack, the synovial fluid will start to invade that crack. Because synovial fluid is all in this space because we're in the synovial joint space. We're still in the capsule. but the cartilage is starting to crack, so that hyaline fluid, the synovial fluid, is starting to creep into that space. So we get all this synovial fluid, starts causing this deep crack to form. And now this crack is getting deeper and deeper. We're starting to get into the blood supply, into the bone itself. These cracks are starting to form and get deeper and deeper. Then we have to repair it. So we do this fibrocartilage plug to try and repair that crack so that synovial fluid can't keep going into that area. So that's where our bone remodeling starts to form, and we get these new bony formations because we're trying to repair that cartilage, but unfortunately it's being repaired with bone instead. So final thing, here's our subchondral bone cyst forming. And again, crack with leakage of synovial fluid into the bone again, causing further problems. So that fibrocartilage plug is not mechanically sufficient, may be worn away, exposing that subchondral bone plate, which can become thickened and eburnated, which is degeneration of the bone. If there's a crack, which is what we have here, synovial fluid gets into that space and causes a subchondral bone cyst. These bone cysts you'll see. And so these osteophytes is what the bone cysts turn into. And that gives you that rough appearance on the edges of these bones from all these bone cysts, these osteophytes that are forming through the synovial fluid leaking into the joint. So here is your normal joint. Really nice joint spacing here, nice and even throughout the joint. Then we have our osteoarthritis. Cartilage is broken off. We have synovial fluid invading into these spaces, causing the bone cyst to form. On the more advanced side of things, osteophytes, periarticular fibrosis, and calcified cartilage. Here's our osteophytes, calcified cartilage, fibrosis of the ligaments of the joint capsule, keeping it all in space. So this is advanced arthritis. The middle one is kind of like in the middle. You're trying to grow it and starting to get degenerative disease. Obviously, they're going to have pain and soreness here. It's going to be a lot worse on that one because the joint is pretty much dissolved at this point, and it's like bone on bone, causing problems. So those are the three things dealing with different stages: normal, beginning phases of osteoarthritis, and then final late stage advanced. So clinical manifestations: joint pain with movement or weight bearing. It improves with rest. So in the morning when they wake up, they're going to feel okay, and then throughout the day, the pain comes back and gets worse. That's usually osteoarthritis. Sometimes they wake up in the morning stiff as well, but it depends on the person. The deep, achy joint pain. Pain signifies joint destruction. The joint may be enlarged, boggy, or tender. So you may have some crepitus. What's that? Popping, cracking. So when you are, if they complain of their right knee hurts. So what leg should you examine first? The left one. Do your whole lifting, bring the knee down, put your hand on the knee to see if you feel any crepitus, or do you hear it as any knee popping as it goes down. Stiffness, especially in the AM, after periods of minimal activity, they may get a little stiff in the morning, but the pain will improve with rest, but they sometimes wake up with it. And obviously restrictive joint movements. Now, when you start getting into musculoskeletal, which we'll do a lot more in the winter, they may be coming in with, oh, my hip is killing me. It really, really hurts. And then you come to find out, you do your history, oh, they have knee problems. And because their knee hurts, to not make their knee hurt, they walk different. But when they walk different, they're not used to using those muscles in that way, and it can cause pain in the joint above or below the injury. So they may be presenting with hip pain, but why does their hip hurt? Because their knee is killing them and they walk differently to avoid the knee pain, but it causes the hip pain. So don't think, oh, it's just that hip find out where else it hurts, what started first, your progression of disease. Here's your imaging. Again, narrow joint spaces. Look at, this is really good, 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 and then look right here. Not much, hardly any joint space at that point. So obviously the arthritis is in that joint because the other ones are fine. Do you see the differences between how joint space narrowing and what you're looking for? Oh, make it a little smaller again. So again, the 4 on the right are okay. That first one is bad. You get osteophytes, bone cysts, bony cysts, and then all those different fractures have to be repaired. Another example of osteoarthritis, you can see good joint space in the knee on this side, but then again, do you see these points of contact right there? That's, and even right here, that are those bony areas, that's going to increase the weight bearing on those points. So there can be a lot more stress on these areas because the joint space has narrowed. That's going to be bone on bone. So when you're moving that, it's going to be a lot of pain, causing a lot of stress on those areas of points. That's why these joint space narrowing is so bad. Here is another one. This is obviously of the femur going into the hip. But you can see hardly any joint space there. There's still some right there. But obviously, that is where the pain is going to be because it's bone on bone. This is all osteoarthritis. Any questions about that and the x-rays and what you're looking for, the joint spaces and everything? Okay, let's take a break. Come back at 10:55. You get 10 minutes. Okay, we'll get started. So the last little bit for today is rheumatoid and then the neuropathic problems. So rheumatoid arthritis, systemic, so the whole body is affected. Chronic, it doesn't go away, it's stable, it's there the whole time. Autoimmune, inflammatory disease with persistent polyarthritis, so multiple joints are going to be affected, usually symmetrical, bilateral, so both hands, both feet are going to be affected. Proximal interphalangeal joint, metacarpal MTP joints, elbows, knees, ankles, and spine. Those are the most common areas where rheumatoid arthritis has its effects. Usually begins in the 5th and 6th decade. Men are less than women, so women 60s and 70s, or 40s and 50s, I'm sorry. 40s to 50s is when it starts to develop and start to cause a problem. Wide range of clinical presentations, so when we go through, not everyone will present the same way, but there are certain clues. Waxes and wanes, so they'll have flare-ups and then it gets better, then they have flare-ups and it gets better. Some will get progressive to the point where it's debilitating and they can't do certain things. As far as what causes it, not really sure. Some genetic and environmental factors. There are some genetic factors. You don't have to know it for this class. They're there. There are some genetic issues. You'll get this a lot more detail in rheumatology with Dr. Ovalle. Remember, everything from here on out for pathophys is stuff that you'll learn in the winter. So all the CMS stuff will come in the winter. Non-genetic factors, here's your smoking again. Because it's an autoimmunity problem, 70 to 80% will have autoantibodies like rheumatoid factor or ACPA. These are considered seropositive RA. What does seropositive mean? It's in the blood, but mean we have antibodies that are attacking the cell. We do have antibodies present. what arthritis do we learn about, which is seronegative? Psoriatic arthritis. There's no autoantibodies. There's nothing attacking it. It's the psoriatic arthritis. Um, so that's what it means by seropositive. There is an antibody. There's something in the autoimmune problem that's causing this problem to happen. All these things contribute to inflammation that occurs in the joint synovium. So now we're talking about the actual synovium, the joint capsule becoming very inflamed. So the joint synovium is very, very normal. We get activated cells, inflammatory initiation with B cells, T cells, and macrophages. Normally, the synovial lining, that little membrane, is only 1 to 3 cells thick, but now it gets thickened to becoming 8 to 10 cells thick. Get some vascular changes. Obviously, with that synovium lining becoming thicker, diffusion starts to be a problem because now we're increasing the distance for diffusion. This is also pathognomonic for rheumatoid arthritis. It's called a pannus, P-A-N-N-U-S. If you see anything with that, think rheumatoid arthritis, because they go together. So pannus is an abnormal layer of rheumatoid arthritic synovial tissue, and this tissue will invade and destroy the adjacent bone and cartilage. So you destroy the cartilage because of the inflammation from the synovial membrane, whereas the opposite with osteoarthritis was overuse injury. Constant use would crack the cartilage, and then the synovial fluid would leak in, causing all those changes. So osteoarthritis is more of a mechanical problem, overuse injuries. Rheumatoid is an autoimmune problem. Your body's attacking the tissue, causing the inflammation, causing this pannus to form, and this inflamed synovial membrane will start to attack the surrounding tissues, degrading the whole joint. So you can see here the differences on the left and the right with your normal joint and the rheumatoid arthritic joint on the right. Inflamed synovial membrane. You can see how thick this line is compared to this one. So that got very, very thick. Here's our synovial fluid. And here's the pannus. We start to invade the bone and the cartilage in that joint space, and it starts to degrade it. So this is called pannus, and that's the degradation of the bone due to the inflamed synovial membrane caused by rheumatoid arthritis. So you can see here in this picture, we get loss of cartilage as we go through. This is our normal. Then we get the pannus formation. And then finally at the end, it's called ankylosis. Whenever you see ankylosis, it means the joint has fused. This joint, when it fuses like that with ankylosis, will not work very well. There's a disease called ankylosing spondylitis. Has anyone ever heard of that? What happens? Basically, it's in your lower spine usually, and the bones fuse, and you can't bend over and do things because of the ankylosing spondylitis. The ankylosing is the fusing of the joint. More severe form of it, but that is what's going on in that one. So a physical exam on a patient with rheumatoid arthritis, they're going to have fatigue. Joint inflammation is going to be the big one. Pain, swelling, warmth, morning stiffness are all hallmarks of the rheumatoid arthritis. Multiple small and large synovial joints, again, we're only with the synovial joints, the ones that move, are affected symmetrically. So both sides of the body are going to be affected. The synovial joints get demineralized. You get joint cartilage, juxta-articular bone. They all get eroded by the synovial inflammation. Again, that's the pannus formation causing joint deformities. We talked about before, when those joints aren't lined up right because you have joint deformities, you put stress on certain parts of the bone, you put the weight-bearing part on certain points, not displaced over the entire joint. That can cause cracks and more problems with that. Pain, so they won't use that joint anymore because of all the pain. If it's in the cervical spine, it can lead to cervical instability. They can't hold their head up anymore. Also subluxation, where the joint comes out of pocket, Ankylosis, the joint fusion can also occur. But again, bony erosions, joint space narrowing on the x-ray. Osteoarthritis also has some bony erosion going on and joint space narrowing. So the history is what's going to do a lot. This is what rheumatoid arthritis does to the joints. So if you ever see this type of deformity in the hands or the toes, usually due to rheumatoid arthritis. They got these type of deformities. And we'll talk about them in a second. So again, symmetrical polyarthritis deformities, boutonniere deformity of the thumb, that's what that looks like. Ulnar deviation of the MTC, or MTP joint, sorry. And swan neck deformity of the fingers. So those are the three things that kind of go along with the hands. Boutonniere deformity of the thumb, ulnar deviation of the fingers, the proximal joint, and then swan neck deformity of the distal phalanges. Extra-articular manifestations of rheumatoid arthritis. So remember, this is an autoimmune disease. So those antibodies can affect other areas as well. Cardiac, it can cause pericarditis and pericardial effusion. They can get rheumatoid nodules. Remember we talked about nodules in derm. We said that certain diseases will form nodules. Rheumatoid arthritis is one of them that will form nodules. But it also can form in the vessels as well. So it's called heart block and bundle branch block if these nodules get into the wall. Lung, you can get pulmonary nodules, pleural effusion with the lungs, if the rheumatoid is affecting these tissues. Not everyone's going to have these. That's why no one with rheumatoid develops the same symptoms, but it depends on where they are. Ophthalmologic manifestations, keratoconjunctivitis, scleritis, episcleritis, and keratitis. And neurological manifestations, cervical spine subluxation, can't hold their head up. And systemic vasculitis. What kind of skin disorder will they have with a systemic vasculitis? How would you describe? Palpable purpura. Palpable purpura. Petechiae is not palpable. That's why we call it palpable purpura. Petechiae, purpura, ecchymosis, none of them are palpable. You can't feel that. But in vasculitis, it's a palpable purpura from the vessels exploding. Here are the rheumatoid nodules. Okay, we talked about them before. Okay, so they have nodules under the skin. This is not a primary derm issue, but the derm manifestation from the underlying rheumatoid arthritis. So there's some examples of rheumatoid nodules and other areas, like a little summary slide, where rheumatoid can also affect different organs and tissues throughout the body. Remember, serology, they're going to have this rheumatoid factor. Okay, that's that seropositive, because they have the rheumatoid factor. Ulnar deviation, the swan neck deformity, boutonniere of the thumb, deformity of the thumb. They can get some splenomegaly, lymphadenopathy, symmetric polyarthropathies. Polyarthritis is the big one. Symmetrical, both hands are going to be affected, both shoulders or whatever it is, but it's usually symmetrical. So here's a good slide talking about your normal versus osteoarthritis versus rheumatoid arthritis and the differences that you would see in the joint. Big thing with rheumatoid, swollen synovial membrane. Osteoarthritis has no problem with the synovial membrane. It's the actual joint itself that's causing the problem. In rheumatoid arthritis, they attack the synovial membrane first, which then causes the problems downstream. You can't stop the process once it starts. You just delay the progression. Last little bit is neuropathic joint disease, also known as Charcot joint. This is why I say go to Disney, because you'll see this a lot. Okay, Charcot joint is a form of secondary This is not a primary problem. Secondary problem, non-inflammatory arthritis. There's no reason this patient have arthritis in that joint. They do because they have a peripheral neuropathy. So they don't have any feeling and sensation on the bottom of their feet. So they continuously injure it all the time because they don't wear the right shoes. So if you ever see people like in a wheelchair and they have a big boot over their foot, that is designed to reduce injury to the bottom of their feet. They're flat-footed, so when they walk, there's no pressure point in different areas. So it displaces the impact across the foot, not on certain points. But it's usually reused injury. They repeatedly injure that foot because they don't feel it. You know, when we go to the dentist and they numb your mouth, they say don't bite your tongue because you don't know how forceful you're really biting, and you can cause a lot of problems. Now imagine that being your foot all the time when you're walking continuously over Legos all the time, you don't feel it. Eventually, from that repeated use, you're going to have injuries. That's essentially what Charcot joint is. It could be the foot, it could be the knee, doesn't matter. It's still the same thing. Progressive joint destruction due to a primary neurological disorder or central motor abnormality. Something's causing them to not walk right or feel things. Peripheral neuropathy and syphilis is here as well. Will cause neurological problems. So most cases, again, loss of sensation at lower extremity. Leading cause of Charcot joint is diabetes. Makes sense because uncontrolled diabetics get peripheral neuropathies, which then can lead to Charcot joint. Other causes, alcoholism, leprosy, hereditary insensitivity to pain. There are some people that just don't have, the pain receptors don't work in their brain, and they don't feel pain at all. Multiple sclerosis is another cause as well. Now, that is the first part. They have the neurological problem. They don't have any sensation in that joint. They don't feel the pain or whatever. But the other part of it is this part. The second key component is preceding injury or trauma to the foot or the ankle, whatever the problem is, the joint. They're going to have some trauma to that area, repeated injury, because they don't feel it. So there's two parts. They don't feel it, and then they repeatedly injure themselves. Okay, undetected because they don't have normal sensation. Because of the poor sensation, injury may not be perceived to be serious. So they'll continue using it like normal, but even though that the pain is very severe, they're causing a lot of damage to that joint. So the joint essentially fragments. We get destruction of the articular cartilage, subchondral sclerosis. We get our bony cyst formation start happening again. And we get products of bone and cartilage destruction, synovial hyperplasia. Autonomic nerve dysfunction. We talked about that a lot. Who gets autonomic nerve problems? We talk about diabetics are the ones who get a lot of the autonomic dysfunction. We're dealing with peripheral neuropathy. Most common cause is diabetes. Therefore, it would make sense that autonomic nerve dysfunction would also be a problem here as well because they're mainly going to be diabetics. So they get vasomotor changes, AV shunting, and result, decreased blood supply to the skin and bone. We need blood to heal and repair. And if you're decreasing the blood supply to an area, they're not going to heal well. Not going to work. So peripheral neuropathy, lack of proprioception and pain, leading to abnormal mechanics, repeated trauma to the area, causing deformities, ligament laxity, repeated injury, and the cycle will result until you get permanent deformities. So this is a Charcot joint. You see how it's almost like a triangle here? But in a normal foot, you have this little bend there. You lose that in the Charcot joint. So the foot will look like a triangle. That's a Charcot joint. Acute stages, rapid progressive bone joint destruction within days or weeks. So acute stage, radiographs are normal. Within 4 months, this is 4 months later, decrease in calcaneal inclination with equinus, unable to dorsiflex, and deformity at the ankle. Bony debris is thrown in there. So basically your foot turns into a triangle. Clinical manifestations, unexplained swelling in that foot. Again, because of underlying loss of sensation, they're not going to have any pain when you ask them if you have any tenderness or pain, and so forth. They will have erythema on the top of the foot or the ankle. That gives it that triangle appearance because all the edema in that area. Increased warmth to the foot. And obviously, early diagnosis and treatment is very critical to a successful outcome. So always, obviously, early diagnosis is so important. Complications, okay, foot and ankle deformity, chronic ulcerations, eventually amputations, instability of the foot. We may need, things to be removed there. So that's sarcoid joint. And then we're done for now. We'll do this last part on Thursday. So we are done. I'll see you guys on Thursday. Good luck tomorrow on your OSCEs.